All right, thank you for the introduction. Always difficult following MPG. I almost texted you last night saying, you know, take your foot off the gas a bit because I'm following you, but it's okay. I'm going to do my best. So today I'm going to talk to you about our experience with a 3D CZT camera at the CHUM, which is the University Hospital Center at the University of Montreal. So I will be talking about specific technologies from Spectrum Dynamics and GE Healthcare, but I assure you that no one has any interest in paying me to do so. So brief market overview of the digital tech that we have in nuclear medicine. So today's talk is focused on the 3D cameras, and there are two. There's the Veriton CT from Spectrum Dynamics, which is the one that we have at the CHUM. There's also a similar product from GE 3D CZT. The one from Spectrum came out around 2019, and the GE one a few years later in 2022. There's also the 2D version of the CZT camera that came out a year before in 2018, just to kind of lay it out there what's on the market. So that's the one that we'll be focusing on today. And we're proud to be the first site to have it installed in Canada at the CHUM. Just in comparison, GE, according to GE, this is data according to GE, they have two operational, one in Halifax, one in Calgary, 8 sold across the country so far, and one of them being sold in Quebec. As compared to the 870 CZT, which is the 2-detector version, many more sold, however, it was on the market before. So 20 sold, 15 operational, and about 2/3 of those are found in Quebec. So as I mentioned, the Veriton, we installed it in November of 2023, so we're coming up to almost a year experience with this camera. It has 12 telescopic detectors that you could see on this picture that approach the patient, giving a field of view of 32 centimeters, and we can image up to 2 meters, which means easily from vertex to feet for most people. So just to give you a comparison where we stood and how it changed, if I compare to a sodium iodide conventional spec camera in terms of workflow, so you have your standard whole body image. Sometimes you do some static lateral heads, call the physician or the resident, where do you want your spec? A couple minutes go by. Okay, you do your spec, and sometimes you even do 2. So you're booking your patients probably every 45 minutes, maybe 1 an hour. Compared to the Veriton, we're able to do images in 15 minutes. So we're able to actually book 2 patients an hour. So right there, you could see how it can dramatically affect your workflow. And that's exactly what happened. So from the time of install, or the time that we started using it in December, we quickly went through our waiting list. And the last date here on this graphic that I obtained from our physicist is in May. And sometime in the summer, we've essentially eradicated all our waiting list in bone scans. And if you can extrapolate this line to September, we're actually doing them now before they're requested. No, that's a joke. So acceptance testing. So if you're not familiar with acceptance testing, it's a bit of outside the scope of today's talk. But for those of you who ever went to the optometrist and they ask you option 1, option 2, and the answer is always option 2. And this is where we have with Veriton. We definitely see the better spatial resolution on this provided image. But how does that translate clinically? So here I chose a perfect case, 38-year-old man coming in for bone scan, diagnosed with HCC. You could see here the vertebrae very well. You could even see the disc spaces. The MIP images is very spectacular, and some of our colleagues even compared this to NAF, to PET NAF bone scan. And based on this image, you can't really argue. And if you were at the CANM 2 years ago and you managed to stay awake, you probably still don't remember that I actually gave a talk on PET bone scan. So I took some images from that talk and put them side by side for you. So on the left-hand side of the screen, the PET, two PET images, one from an old BGO PET, which is attenuated corrected, one from a LYSO PET, which is non-corrected. And on the right side of the screen are the two 3D CZT images, one from Veriton and one from StarGuide. And you could see very well that, yes, the images are quite comparable in quality, which is definitely very encouraging. But that's not the type of patient we see every day, do we? We kind of see the other end of the spectrum. Older patients, we use this camera specifically for oncology. So how does that compare? Well, I found another patient which is more or less representative of that population. And if we put it side by side with the normal bone scan, we don't really see the same thing. And I know what you're going to say, because I thought the same thing as you, is that, okay, well, what's going on here? We could see a few things different. In the lumbar spine, we kind of get this loss of uptake. And in the thoracic spine, there's increased linear uptake. And if you notice on the CT, the lumbar spine is demineralized. Well, probably most of the spine is demineralized. And on the thoracic spine, you have increased density corresponding to osteophytes or calcification of the longitudinal ligament. And the resulting picture, specifically on the spectrum dynamics camera, we learned is explained from the partial volume correction that is part of their corrective factors. So partial volume correction. So basically, you take the phantom on the left and you correct the uptake with the different Hounsfield units. So what it does is it constrains the activity within a certain anatomical region. As you see, as the corrected picture on the right, we're able to see the spheres or the cylinders right down to the last one, whereas on the original picture, we don't really see that. So that's what we're seeing here, is that if we go back to the other picture, it's kind of enhancing these denser spots on the picture, which permit us to see the smaller lesions, but also have the added effect of maybe enhancing certain artifacts. So here, I took the first patient, our normal bone scan, and I compared side by side PVC versus no PVC, so partial volume correction and without partial volume correction. So you could see what the impact of taking that correction, taking out that correction does. So the image isn't as clean. You still kind of see the spine pretty well, the disc spaces too, but it's not as a nip and tuck as it is with PVC. And if we look at our other patient, 89-year-old man coming in for evaluation of prostate cancer, who has many benign changes, the spine definitely looks a lot less sharp as compared to with PVC, and reminds us maybe what we're used to seeing with NAI. So with this PVC algorithm, basically allows us to do more with less. So it diminishes scan times. all right? So it optimizes our efficiency because it permits us to get an otherwise unimpressive image to something that's a lot more appealing very quickly. If we don't want to do it with, oops, okay, sorry. If we don't want to do the CT, we would have to increase the time of acquisition for the native SPECT, and we lose that advantage of performance. However, it does require a period of acclimatization for the reader, because now you're looking at these partial volume corrected images, and well, they look different. They look different than what we're used to. So you have to get used to it, and I had to get used to it, and so did my colleagues. The other thing that I have to note here is that it comes with whole body CT. So if you want to use the partial volume correction and you want to go fast, well, it implies that you're scanning everyone with whole body CT. So that's going to increase your reporting time. But ultimately, we're able to see smaller lesions with this corrective algorithm. Just a couple pictures head to head. So this is a patient that came in for bone scan, Veriton on the top, the conventional camera at the bottom. There's about a month and a half difference between the two, not much change. The purpose here is just to kind of give you a visual comparison if we had done it side by side. So 1.5 months isn't that much, allows us this visual comparison. So again, images from Veriton, a lot cleaner, a lot sharper, permit us to perhaps see smaller lesions. Because it's a 3D camera, there are no planar images. So the whole body 2D image doesn't exist anymore. But just like with VQ, with lung SPECT, that we do lung tomography, we're able to recreate these static images. So it's like a pseudo-static image. So on the right side, you see the whole body image that's reconstructed using the Veriton 3D data, which actually doesn't look that bad. It's not as good as our traditional whole body scan, but it's a close second. And indeed, we can do anterior, posterior, lateral views, no problem. Here's a case where separated by 7 months, Veriton on the left, conventional on the right, and this patient is progressing. So, in this case, perhaps not so difficult to identify that certain lesions are more intense or there are new lesions. But it's difficult when the differences are more subtle. So it's not advised to scan a patient on one type of camera and then the next time on a different type of camera and then come back to the first type of camera. What we did is basically we had this like washout period where all our patients that were being referred for bone scan, we started doing them on the Veriton, and for the first 3-4 months, we had all our comparisons, Veriton compared to conventional, which is a little bit painful. But now, a year out, we have very few of those left. So now we're comparing Veriton to Veriton, and that's what we're going to continue doing. Same patient, just some SPECT images to highlight what I said. So there are pitfalls. So with the partial volume correction, it does allow us to see small lesions. However, it also accentuates structures with high attenuation and small volume, such as pacer wires. So here, if you look at the bottom image, the CT, patient had a pacemaker, and on this slice, we see the pacer wires. And on the top image, we have the bone scan, and we have kind of linear foci of uptake that are corresponding to these pacer wires. And then once we remove the partial volume correction, that uptake went away. So you could ask yourself, well, if I'm seeing pacer wires that I'm not supposed to see on bone scan, what else am I seeing? So this is one of the pitfalls of the camera, using partial volume correction. To further illustrate the limitations, this is another case, 66-year-old man with metastatic castrate-resistant prostate cancer, comes in. I'm showing you a slice here of the pelvis. The cursor is on the right sacral ala. There's a sclerotic lesion, not too sclerotic, but still sclerotic. The Hounsfield units aren't terribly high. On the bone scan image, we don't really see too much uptake corresponding to that sclerotic lesion. This patient was enrolled in one of our many research trials for prostate cancer. So because of the protocol, required us to repeat the bone scan on a conventional camera because that's what the protocol said. The top image was just a clinical scan requested by the oncologist. So 7 days later, patient returns. We do the same study on a sodium iodide camera, and now we have uptake. So that's weird. So then we went back and we looked, okay, what if we remove the PVC, partial volume correction? Then what? Well, it helps. We don't really get as much uptake as with the conventional camera, but it is better than with partial volume correction. So obviously we need a tiebreaker here, and luckily the PSMA is definitely a tiebreaker. This is a true lesion that we saw on conventional imaging that we saw less well with the Veriton. There is a week apart. So you could say, well, what if that lesion progressed? Maybe. There were other lesions here in the iliac wing that was positive on PSMA and was positive on the conventional camera that we didn't really see on the Veriton. When we compared the patient, the other lesions, they were well seen. So even if a week had passed by, it was really just those two lesions. So we don't really have the answer. The company's aware. We our working solution is to reconstruct both with and without partial volume correction until we can kind of get a good sense of it. I would say for the most part, it works well with partial volume correction, but this is an example where I guess it failed to. So I'm wrapping up here. This is the next few slides is preclinical. So we're not applying this at our center, but I found it was very important to mention. So place of artificial intelligence in bone scanning. So basically here the concept is you take your image, you apply neural networks to work the image, and then you have a noise-reduced image. And why am I talking about this? Well, this is the same patient reconstructed in a standard method, and the other line, the other row, is about half the time, half the acquisition time, with noise reduction. So take a few seconds and look at the image, and we found that these two images are very, very similar. So the top row, 7-minute acquisition with noise reduction, and the bottom row is the standard acquisition, the 12-minute acquisition with standard corrective factors. So if we can essentially cut the time in half, imagine how much more productive we can be. So I'll just reiterate that we're not doing this clinically. This is just experimental, but very, very interesting. And with this noise reduction, just to highlight that if you quantify a lesion, we maintain the same SUV, so fairly reliable. So deep learning and digital cameras. these algorithms require high signal-to-noise ratio, so you need a digital camera to do this. We can't really do these manipulations on a conventional camera. The other point I'd like to mention is a shift of focus to productivity. We're used to equating image quality to advancements, but what really I think with AI and what's coming down the pipeline, we need to focus really on lesion detectability, not necessarily image quality. As long as we could see the lesion and diagnose it, that's what we want. That's what's going to make us go faster. And this increased productivity is very much the key metric for justifying the price tag to the ministry for camera budgets. Last slide here, last couple of slides. Out of the scope of this talk, but definitely many applications to this camera, specifically the exams that are the one-bed exams, lung, brain, cardiac, definitely interesting for that. So in summary, this camera, very positive experience. We managed to definitely reduce our waiting lists thanks to the increased throughput. But one thing to mention and keep in mind is that this partial volume correction, although it may help us detect smaller lesions, at least in a few examples, overestimated certain dense structures, and it may even underestimate low attenuating osseous lesions. Companies aware they're working on improvements. AI, deep learning, definitely very interesting to cutting times even further. And this is, where I see these applications in terms of increased productivity and in terms of the future. So thank you very much.